Hello and welcome, everyone. Good morning or good evening, depending where you're calling in from. My name is Megan Mooney. I'm the Director of Engagement and Partnerships at IHME. I'll be your facilitator today. I'd like to extend a very warm welcome to everyone joining us. Thank you so much for coming to this session, GBD 2023 Critical Findings and Their Global Significance, with Dr. Christopher Murray, who will be our presenter. This is the first session in our GBD 2023 in Focus series. We gave another version of this earlier this morning. Thanks to Dr. Murray for being with us twice in one day. He will provide an overview of the GBD 2023 results, followed by, we have other sessions following over the next 3 weeks, which will give you an in-depth look at each of the 3 GBD capstone publications for this round of the GBD. As this is an exclusive session for GBD collaborators, it's really important to begin by recognizing the contributions of each of you and together our collective achievement in publishing GBD 2023. Thank you so much, and we hope to continue working with you on GBD 2025, and work has already begun on the next update. The GBD 2023 is the latest update to the Global Burden of Diseases, Injuries, and Risk Factors study. The GBD, as you all know, is a systematic and scientific approach to understanding health loss due to injuries, illnesses, and risk factors for all ages, by sex, for all locations in the world from 1990 to 2023. And at its very heart, it can help to serve policymakers to understand where and how their country's health systems are working and where there are challenges. So if you haven't yet signed up for any of the upcoming sessions, please go ahead and do so. You can access registration links on the collaborator portal. And with that, I will introduce Dr. Murray, who will be our presenter today. Dr. Murray, as you all know, is the co-creator of the GBD and its principal investigator. Let me tell you just a little bit about his background. Dr. Murray is the founding director of IHME, an independent research institution at the University of Washington. Our purpose and our mission is to provide rigorous and comparable measurement of the world's most important health problems and to evaluate the strategies used to address them through the application of innovative scientific methods. Dr. Murray leads the GBD study. He's the co-author of the original Burden of Disease framework. He's a professor and a chair of health metric sciences at the University of Washington. He has a Bachelor's of Arts and Sciences degree from Harvard University, a DPhil in International Health Economics from Oxford University, and a medical degree from Harvard Medical School. His career has focused on improving population health worldwide through better evidence, and his work has led to the development of a range of new methods and empirical studies to strengthen health measurement, analyze the performance of healthcare systems, understand the drivers of health and health loss, and produce forecasts of the future state of health. Before Dr. Murray begins his presentation, I'll just make a few points about housekeeping. In today's session, we will have about 30 minutes of presentation. Dr. Murray will walk us through what he finds to be the most interesting key findings from GBD 2023, and then we'll have about 20 minutes for question and answer. And you'll have the opportunity to pose any questions you may have. Out of necessity, all of the mics are muted, so if you would like to ask a question today, please use the Q&A function that you'll find at the bottom of your Zoom screen. And we'll be watching those and we'll be responding to some of them directly and raising others for Dr. Murray to to answer. So with that, I will pass the floor to Dr. Murray to share his slides and begin his presentation.
Thank you, Megan. Let me shift over to the slides. And there we go. Okay, so let's see why it's not working. There we go. So I like to think of the GBD as a rules-based evidence synthesis for global health. We have very clearly defined evidentiary rules for the type of data that we use in the GBD and approaches to standardizing it and curating it so that we can provide the world this comparable database on health outcomes. The GBD is a time series, so every single time we release a GBD study, we have re-estimated the entire time series so that it's always giving you a comparable sequence of estimates for each outcome. That if there's a change in data or methods, that is reflected all the way back to 1990. It covers 375 diseases and injuries in its latest iteration, 3,500 plus clinical sequela of those diseases and injuries, and covers 204 countries and territories. And we publicly release subnational estimates for 20 countries, and there's several other countries that are in process. We also have the calculation of the attributable burden. So these are counterfactual estimates for exposure to 88 risk factors. And so we have these two different frameworks within the GBD, as you know, the cause, the diseases and injury framework, and then the risk factor framework. And as I'll notice on the picture here, we have released the GBD 23 capstones, and the Lancet put together a nice combination of those papers for the World Health Summit release last week. One of the characteristics of the GBD since our first installment for 1990, produced initially in 1993 for the World Bank's World Development Report, and then subsequently updated and revised. But one of the key things is that we had traditional measures, disease, injury, and prevalence, incidence, death rates, age-specific death rates, cause-specific death rates, age-standardized death rates, et cetera. But we also produce these rolled-up summary measures which help decision makers get a high-level view of the burden of disease. So since a death at young age represents a greater loss of potential health than a death at age 95, we calculate years of life lost due to premature mortality, YLLs. We take the prevalence of all those clinical sequela that we estimate and the public's view of severity and multiply the two together to get years lived with disability. And then we take the sum of those two, YLLs and YLDs, and that's DALYs, one of our apex measures that you're well familiar with. And as you know, we take the whole matrix of all this information and also calculate a positive measure of health, namely healthy life expectancy. A critical aspect to this study are yourselves, the collaborators, and we have within the collaboration now more than 17,000 collaborators in 167 countries and territories. The map shows where they're distributed, and it's a critical aspect to the study. It's really why I think the GBD is become the de facto standard for health measurement around the world. I mentioned the 20 countries where we do subnational burden, and now we are adding in the next cycle of GBD, which will actually be GBD 2025, not 24, working with Santé Publique in France. We will have subnational burden for France, including for its overseas territories, as well as subnational burden of Saudi Arabia, working with the Public Health Agency there. A key aspect to the GBD is that you, and I will be using GBD Compare, our flagship data visualization, for most of the slides I want to show you, just so that you have an idea of the types of views, if you haven't already used them, that you can get from GBD Compare. It's a very powerful tool for exploring the data and getting an understanding of what's in the GBD. But we also have online a data catalog, the Global Health Data Exchange, which gives you the metadata for all the sources used in the GBD. And then we have about 320,000 sources, GBD 2023. And to give you an idea of what a source is, the vital statistics for a country in 1 year is a DHS survey in a country is a single source. So altogether, 320,000 or so sources for which the metadata is described. All right, let's talk about results. This is not in the actual paper, but you can extract the data and get it. It actually comes from our forecasting paper published last year. But basically, it shows you life expectancy from 1990 to present, and then forecast into the future. And what the life expectancy for women on the left and men on the right shows is, with ups and downs, steady progress in life expectancy. The big drops during the COVID epidemic, recovery post-COVID, and some narrowing of the gap between high-income regions and sub-Saharan Africa over the course of the 33 years shown on the slide. And yet there are still very substantial disparities that remain. Now, another way of looking at life expectancy is this interesting view that you can get in GBD Compare, where for any set of geographies and for any time interval, you can look at the change in life expectancy, and then what are the causes contributing to that change in life expectancy. So let me explain this a little bit more carefully. This is for World Bank income groups. And the vertical line is life expectancy in 1990, and the dashed vertical line is life expectancy in 2023. And so the shift to the right from the vertical line to the dashed line is the change in life expectancy. So for low-income countries, life expectancy was around about 52 and has gone up to about 64 over that 33-year period. And then the change is broken into the causes that contributed to the change. And all the red causes are communicable, maternal, neonatal, and nutritional causes, group 1 in GBD speak. Then you can see the blue causes are the NCDs and green are injuries. And in low income, lower middle income countries, the improvement is almost entirely driven by reductions in communicable maternal and neonatal causes, whereas the improvement at the other end of the spectrum in high-income countries is driven by reductions mostly in cardiovascular disease and somewhat in cancers. Now, left of the vertical line are things that have gotten worse. And so you can see a slightly light blue color in the high-income world, and that is increases in drug use disorder deaths that would have, on its own, reduced life expectancy and makes up part of the picture between the change that we observe. Now I'm going to change from looking at World Bank income groups to looking at GBD regions and show you now just for males the change in life expectancy. And you can see that not every region had the same changes, so that the ordering of regions changed from 1990 to 2023. The worst in 1990 was Eastern Sub-Saharan Africa, but now the worst in 2023 is Central Sub-Saharan Africa, with the life expectancy just around 60. And then likewise at the best, we now have the highest life expectancy for Australasia, around about 82 for men, for the region as a whole. But that general pattern of most of the improvement in the Sub-Saharan Africa, South Asia, Oceania, due to reductions in communicable maternal and neonatal causes is evident here. You can see in Southern Sub-Saharan Africa, the dark red to the left of the vertical bar is increases due to HIV. And you can also see some increases in a number of regions like Eastern Europe in light green, which is due to suicide. Now for females, very similar pattern, except the whole curve is shifted right because female life expectancy is higher than male, still to this day. And you can see that now we're up to the lowest life expectancy in Central Sub-Saharan Africa for females, around about 64, and the highest for men is about, for females, is now in high-income Asia Pacific at about 87. So higher for, but the same general pattern we were describing a moment ago for males. Now, if we look at the country level, we see life expectancies go from, for both sexes combined, in 2023 from the low end of 55 in the Central African Republic to the high end of Singapore at 85. So a 30-year span in life expectancy in 2023, with particularly low life expectancies in Central Sub-Saharan Africa and the Sahel, as you can see on the map. Now, let's have a look using tree maps, which are a visual that we use in GBD Compare. It's a rectangular pie chart. So the proportion in this case of deaths in 1990 at the global level due to, let's say, stroke or ischemic heart disease is reflected by the area of each of those boxes. Back in 1990, NCDs accounted for about 50%. And you can see the big contributors there are stroke and IHD and COPD, somewhat from diabetes and CKD, lung cancer and stomach cancer stand out. But there's a lot of deaths still in the world in 1990 from the communicable maternal and neonatal causes in the red-orange colors, with predominant contributions from measles, lower respiratory infections, diarrhea, neonatal causes, malaria, and a little bit from HIV. And then the last set of boxes is injuries in green, with drowning, falls, self-harm, that's suicide, and road injuries and violence as the main contributors. Now, fast forward to 2023, and the blue boxes have expanded, and that's a reflection of the very substantial transition towards NCDs in the world, driven by many factors, aging being a critical one, but also declines in age-specific death rates for communicable maternal and neonatal causes. So in 2023, we have big boxes due to stroke and IHD. Alzheimer's now showing up is quite big. CKD, that's chronic kidney disease and diabetes, and chronic obstructive pulmonary disease as big contributors. Within the communicable maternal and neonatal causes, we have lower respiratory infections. You can see still some COVID deaths in 2023. Neonatal causes, malaria, diarrhea, and HIV rounding that group out. And you can see falls is starting to be a little bit bigger than it was back in 1990 amongst the injuries. Now, we don't like deaths as a measure because to argue that a death from, let's say, a stroke at age 95 is the same health loss as the death from a neonatal cause of an infant or a neonate doesn't seem right. And that's where we have prefer the measure DALYs, which both captures how much life you've lost due to premature mortality, the YLL component, but also causes that don't kill you, but cause substantial functional health loss, such as mental health disorders or musculoskeletal disorders. So looking back in 1990 at DALYs, we have NCDs less than half the burden, so closer to 45%. Still big contributions from stroke and IHD, but you start to see depression, anxiety, back pain, neck pain, headaches, hearing loss, blindness coming through in the DALY table that you didn't see when we were looking at deaths. And then you can see amongst the communicable maternal and neonatal causes, things like iron deficiency coming in as an important cause of disability and not really of mortality. Fast forward to 2023, and you can see the epi transition in a very marked fashion, with now well over the majority of burden globally, actually about 65%, due to NCDs, with contributions from cardiovascular disease, cancers, diabetes prominent, but all that cluster we were talking about even back in 1990, but getting larger: anxiety, depression, the musculoskeletal disorders, hearing loss and blindness rounding that group out. Now, I've pulled off from GBD Compare the same 2023 tree map for DALYs for low-income countries alone, just to highlight how in the low-income world, we still are in a setting where the communicable maternal and neonatal causes are dominant, with neonatal causes, malaria, pneumonia, HIV, diarrhea, measles, and meningitis and pertussis still coming through as important cause in those settings. And you can see in low-income countries, conflict now showing up as an important contributor to injuries, along with road injuries and falls and drowning. Now, just to drive home this point that different metrics give you a different view of burden, I've taken from the tools from GBD Compare the rank ordering of causes of death on the left, causes of YLLs in the middle, and causes of DALYs in the far column on the right. And it's useful to look at how these change because it reflects both taking into account the age of death as well as taking into account the non-fatal outcomes that matter so much. So look at something, for example, like neonatal disorders. 10th as a cause of death globally, but third as a cause of years of life loss because it's affecting very young children. And then when we look at DALYs, because there's considerable disability associated with some neonatal disorders, some of which can last for many decades, it shoots up to number 2. In contrast, if we look at something like diabetes, it was 6th as a cause of death, drops to 10th on YLLs because the average age of death from diabetes is a bit older than some of the other causes, like malaria or diarrhea or HIV/AIDS, but goes back up to 6th for DALYs because there's considerable disability associated with all the clinical sequelae of diabetes or functional health loss. And you can trace interesting examples of that 2 aspects as we transition from deaths through to DALYs and how it changes the numbers quite substantially. Now, moving on to risk factors. And before I do, I want to remind you of the transition we started a couple of years ago in GBD 2021 to using our burden of proof methodology to establish the relative risk curves that we use in the GBD. So in the burden of proof, we have a standardized way of doing meta-regression to get the risk curves for any exposure, but also to score the strength of evidence that we see for a risk outcome pair. We have published so far both the methods in Nature Medicine and then 15 separate papers in Nature family journals to characterize the risk functions that we then use with exposure data to come up with attributable burden. There's a tool online. I hope all of you are already using it, but just as a reminder, the burden of proof tool gives you access to the relative risk of a risk outcome pair, the star rating of the strength of evidence, and you can hover over each of the data points that give you the exact studies that we use to come up with these risk curves. So that's a very handy tool as you dive more deeply into the risk factor component. On to the results for the risk factors. So like in the cause hierarchy, where we have levels in the hierarchy for diseases and injuries, so at the biggest level, we have communicable maternal neonatal causes, then NCDs, then injuries. Go to the next level down, level 2, we have 22 groupings of causes. And then when we go to the next level below that, we get into more detailed causes, like a site-specific cancer, let's say breast cancer. Likewise, on the risk factors, we have 88 detailed risks, but we have these groupings of risk factors to give you a higher level view. We put all 15 components of diet together for dietary risks. We put various types of child malnutrition and maternal malnutrition together in malnutrition. We put together indoor and outdoor air pollution at this level into air pollution. And so we can use in the tools different views, more aggregated risk categories, risk factor categories, or the more disaggregated. Here, using the more aggregated categories, malnutrition is still number 1 in the world. It was much larger back in 1990, but remains at the top. But then we start to see high blood pressure, air pollution, tobacco, diet, high fasting plasma glucose, and high body mass index, that is overweight and obesity, as the top risks at the global level. And we'll talk more about obesity in a moment. Drilling into the detail, the list of 88 risks, and this just showing not all 88, but the top risks, then you get a slightly different view of the dominant risk factors. High blood pressure is now at the top, then high blood sugar, smoking, low birth weight, overweight and obesity is number 5. Outdoor air pollution or ambient particulate matter comes in next, then indoor air pollution, short gestation, kidney dysfunction, high LDL cholesterol, and then lead, and on down the list. So you can see that the way you perceive what is the most important risks depends on the granularity that you're interested in. And one of the nice things about GBD Compare, as opposed to what we can stick into a published paper, is that you, the user, can drill in and take whatever view you want to understand the effect of different risk factors. Now, shifting to low-income countries, again, the risk profile looks very different. Suddenly you see lots of red colors, meaning these are risks contributing to the communicable maternal and neonatal causes. And the top list for low-income countries are its low birth weight, household air pollution, short gestation, child underweight, child wasting, unsafe water. Then you get high blood pressure creeping in, back to the risks of poverty and infectious disease, child stunting, unsafe sex, unsafe sanitation, and hand washing. So the risk factors that dominate really depend where you're looking and what stage of development the country is and what region you're in, because there's a lot of regional variability in risk exposures as well. Now, I want to tease out certain key themes that emerge in looking at the GBD. And so first is looking at child and adolescent mortality together. So I'm using here the probability of death between birth and age 20. So many of you will be familiar with thinking about under 5 mortality or 5Q0. Here I'm adding in deaths during adolescence as well. Now, what we see for low income, lower middle income, upper middle income, and even high income countries is marked progress over the last 33 years. A drop from 23% probability of death between birth and age 20 down to 10 in low income regions. So really substantial progress even in the worst off places, but still huge disparity in 2023. A tenfold difference in the probability of death from birth to age 20, comparing low income to high income regions. And the map on the right shows the same quantity. And you can see the places with the highest levels of child and adolescent mortality are concentrated in the Sahel and extending all the way over to Somalia. So that latitude in sub-Saharan Africa has by far and away the highest levels of mortality for children and adolescents. Now, combine that with the fact that the total fertility rate remains very high in those same places with the highest child mortality, and those are intertwined, right? We know there's a link between birth spacing and child death rates and high fertility rates in less educated women, again, all correlated with each other. So it's a combination of high fertility, TFRs over 6 in the dark red countries, high child and adolescent mortality, and of course, high poverty, and also the places where climate will have the biggest impacts. So you can see there's a growing concentration of challenges in now and into the future in the Sahel and extending over to Somalia. Okay, second general reflection that comes through in GBD 2023 is this huge shift that I started with using the tree maps, but now I'm showing you with the line plot on the left, the percent of burden in World Bank income groups due to NCDs. In all of them, it's going up, and most dramatically in lower middle income countries, going from 25% in 1990 due to NCDs of burden up to 57% in 2023. But in all groupings, there's a big increase. What that means is that middle income countries, particularly, but low income to a lesser extent, are rapidly changing. They've changed in the case of lower middle income countries to where the dominant share of burden is NCDs, but very often ministries of health and the leadership of them struggle to re-equilibrate to this change in epidemiological reality. And very often we see governments still focused on the agenda around maternal and child health and not paying enough policy attention to what has happened in the last decades, which is this huge shift in the burden profile. Observation number 3, we see that mental disorders as a share of burden and rates and prevalence, however you want to measure it, is going up. Going up in the data. It's particularly going up, as shown on the right-hand side, for the causes of depression and generalized anxiety. It's going up in low, middle, and high-income countries. And there's quite a lot of debate as to why, but part of it was COVID, but it started well before COVID. And that increase before COVID and after, some people assign it to the use of devices and social media. Others point to sort of greater challenges for younger generations, at least as they perceive ahead in the future, and the changes in family structure, organization of society. Many theories out there, but what we know empirically is that there is this increase in mental health disorders. Another topic that we draw attention to in the GBD, and here on the left, I'm now showing numbers of deaths, because that's the usual metric in this field around looking at climate and health, is looking at numbers of deaths related to heat. The global level, about 250,000 deaths attributed to heat in 1990, going up to 550,000 in 2023. So that is getting towards 1% of all deaths in 2023. And of course, that number is expected to go up substantially over the course of this century. Now, what's interesting about heat is the panel on the right shows that it affects all age groups with different causes affected. It's affecting respiratory infections in children. It's affecting cardiovascular disease, the blue color, and diabetes, the purple color in older adults. And it's affecting suicide and homicide and transport injuries, the green colors, in the sort of younger adults to middle-aged adults. So it has diverse effects across the age range. Now, we draw special attention to obesity. When we looked at the the detailed risk level for DALYs, the global level, overweight and obesity was already ranked 5th, but it's of the major risks, the top 10 risks, it's the only one that's steadily going up everywhere. And you can see that on the left panel, where the fraction of DALYs due to obesity is just rising really dramatically. Look at upper middle income countries going from 2% to 6% over the 3 decades. And on the right-hand side map, you can see places in red where over 10% of burden is already attributable to overweight and obesity. So a risk that deserves really special attention because it's large and steadily increasing all over the world. Another thing that came in GBD 2023 was that the evidence of the direct relationship between lead and cardiovascular disease, particularly ischemic heart disease, was strengthened. In the past, we had lead affecting high blood pressure and then on to cardiovascular outcomes. But now the evidence met the threshold for inclusion for the direct effects, which are quite a bit larger. So lead is now jumped up to being ranked 10th amongst risk factors, more than 3 million deaths related to lead, and highly variable across countries, given the different mechanisms of exposure to get lead from petrol all the way through to cookware and the way different spices like turmeric are prepared. Another addition in the GBD 2023 was through burden of proof analyses. The evidence was put together of a much broader set of causes related to sexual violence against children. That's reflected now in the GBD, where we now have, starred relationships for 14 causes, and previously there's only a small number. And so that's a major change in our understanding of the effect of sexual violence against children in adults when they grow into being adults, and thus the burden turns out to be much larger than previously understood. Another aspect of the way we think about the GBD is to use this highly curated, standardized database to develop insights into how health systems are performing. So several years back, we introduced a measure that was developed from the 1970s and then revised by Martin McKee and Nolte to look at amenable mortality. And we took the GBD database, we took that concept that there are some causes that are very influenced by access to healthcare, use the GBD risk factors to risk adjust a number of death rates, and then put them together in this index called Healthcare Access and Quality, which gives us some insight into how health systems are performing using risk-adjusted outcomes in the GBD, and using that concept of amenability to give us those insights. Another way which was published in August, not last week, but in August by Joe Dielman and Amy Latsuka and the team at IHME that looks at healthcare financing, is to use the healthy life expectancy results and look at expenditure data to use a method in health economics called stochastic frontier analysis to look at what is the best level of healthy life expectancy you can achieve for a given level of healthy total health expenditure, controlling for SDI. And then how far away are you from that best level? That best level is called the frontier. And you can see in this analysis that a low spending, low SDI place like Niger is close to the frontier. Turns out Niger has been very successful in delivering vaccinations as part of that story. And a high spending, less successful country for its level of spending and SDI, the US, looks to be far from the frontier and shown up here in red. So I expect to see more and more use of the GBD curated database to look at efficiency and performance of health systems in the future. So that's a tour through some of the results, and now I'll turn it back to Megan, who will help field questions that you might have on the GBD results.
Thank you so much, Dr. Murray, and thanks to those of you who've already put questions in the Q&A box. Please keep adding them. Let's see here. Why don't we start with how did the GBD 2023 findings reshape our understanding of the post-COVID-19 global disease burden, especially regarding NCDs?
Well, during COVID, we of course had a big shock. We had a big increase in communicable maternal neonatal causes because that's where we assign COVID. Interestingly, COVID was very concentrated in older age groups because the two risk factors for COVID that really mattered were obesity and age, with age being the most important. And so that shrank briefly in 2020, 21, 22, the share of burden to NCDs. But now that we're sort of back to 2019 life expectancy and disease patterns, we're seeing the effects that I showed on the slides of the steady transition towards NCDs. And it's a transition that's moving very quickly, as I mentioned, driven by both aging, but also by reductions in the communicable maternal neonatal age-specific death rates, once we got over the COVID epidemic. So that's sort of the main effects that we're seeing as I described on the various plots.
This question came in early on, so I think has been addressed, at least in part through your presentation, but I would just ask you to elaborate on whether the GBD 2023 analysis captured any new insights that you haven't mentioned yet on mental health, substance abuse, or climate-related health burdens.
So I mentioned already the mental health findings. I mentioned a little bit about the temperature findings. There's a lot more work underway for next year on climate and forecasts of climate and health out into the future. So there'll be a bigger body of work coming, but certainly the direct effects of temperature, both heat and cold, are in the GBD and pretty well characterized. Uh, for substance abuse, one of the things that was highlighted in the paper on demography was this very marked increase in North America and Central America in the death rates in the age groups 25 to 39. And in some places, in those age groups, mortality has gone up 60% in the last decade due to drug use disorders. There is some suggestion now in the US that that's starting to come down, but the jury's out a little bit to know how much of a reduction there is. But as you saw in the boxes and in the change in life expectancy, even at the super region and the regional level, we can see the effect of this drug use epidemic that's being underway.
Excellent, thank you. We have another question here about chronic kidney disease of unknown etiology. And this individual is wondering whether chronic kidney disease of unknown etiology is considered under the CKD classifications. And they note that CKD-U disproportionately affects disadvantaged populations in Latin America and South Asian countries, and prevalence data are now increasingly available. Personally, they believe it's a condition that deserves greater attention, and they also note that they apologize if it's already recognized in the cause list and they haven't perceived where it is.
Yeah, it's in the other CKD category. It is why we see when you look at a country like Mexico that CKD is so large, and a lot of that burden. I mean, they have obviously CKD from diabetes as well, because of the high prevalence of diabetes. But the CKD of unknown origin is there, and the data is strong in Mexico, so it's well represented there. But that's where you'd find it on the cause list. It is a very interesting phenomenon, as obviously the person asking the question knows, and a lot of controversy over what might be behind it, and lots of interesting theories. I think the jury's out as to the actual true cause behind it.
Switching tracks to maybe a broader reflection on GBD 2023 as an update, how has the integration of real-world data or machine learning methods enhanced the precision of GBD 2023 estimates?
Real world data somewhat through the use of claims data and electronic health record data for the countries that share that sort of data with us, and that increasingly gets fed into the modeling with appropriate tests to try to correct for underdiagnosis, particularly in groups that are excluded from those types of systems. But it's super useful for many causes. For machine learning and AI, the way we've used it in GBD23 is limited but interesting. We use it, for example, in ingesting all the data on conflict and on disasters, because that comes with very detailed descriptions of particular skirmishes or conflicts, and we need to classify that information, assign it to a GBD cause in a location and a time frame. And that used to be done by people, and now we use the LLMs to do that as an example. We have tried to use machine learning to speed up some aspects of systematic reviews, particularly the title abstract part. That works well. And we're more generally trying for the future to look at a range of ways that the LLMs can be used to enhance really all of the different steps in the pipeline of GBD all the way through to, publications and preparing some of the documentation um, for, supplemental appendices and things like that.
Thank you. Sticking with the theme of maybe broader reflections on this cycle, um, we have a question from an academic research perspective. What thematic or methodological gaps identified in GBD 2023 do you think should be prioritized for collaborative investigation in the next research cycle?
Um, well, I think the areas where I mean, there's many areas where we can all do a better job. It's such a vast undertaking. All the way from, trying to understand better mediation of risk factors between each other. We have a mediation matrix, but that's an area both methods wise and data wise. There's a lot of work that could be done to better understand risk mediation. How much of obesity is through blood pressure, et cetera. We are in a transition on the modeling front, where we are moving from using CODEM on causes of death to one mod COD, which we use the one mod framework for all-cause mortality this cycle. We are rolling that out for causes of death, and all the tests so far suggest it's an improvement in terms of skill, in-sample and out-of-sample skill. There's the whole transition on modeling incidence and prevalence in an internally consistent way, going from DISMOD-MR to DISMOD-AT. I think there's a lot to be learned about using those new tools, and ways to improve them, because obviously no tool is going to be perfect on its first iteration. I think there's work to be done on trying to see which diseases and injuries may interact with each other and lead to comorbidity. So we have in the GBD independent comorbidity when we calculate YLDs and look at the distribution of comorbidity. But we would like, and we would hope it will occur, to capture the dependent comorbidity. For example, drug use disorders and mental health disorders, or diabetes and ischemic heart disease. So there's a lot of methods and/or empirical work that would be really important to see happen in that space, as well as the world in an aging population. There's more and more policy interest, I think, in understanding comorbidity. Who are the frail, who are getting multiple diagnoses, because it changes how you deliver care. So it's a demand, a question we get from many groups, in government particularly. You're muted, Megan.
We have another question here from a Dr. Sayed who asks, in GBD estimations of sepsis and similar syndromes where ICD codes may not be very accurate, are published data on specificity and sensitivity of ICD-based diagnoses utilized to correct the estimates?
We haven't used published sensitivity and specificity. What we've done for sepsis is we have developed, over the course of the antimicrobial resistance and sepsis body of work, a deeper dive into ICD coding to find all sorts of garbage codes and other places where sepsis deaths get assigned. And then we figure out, using those both direct and indirect sepsis codes, how many people have different infectious syndromes. So think respiratory infection, kidney infection, on down the list. We have about 20 of these infectious syndromes. And we can try to construct up sepsis incidence and sepsis death from that approach. So, and in general, sensitivity and specificity on death data is sort of problematic, because if you think about the matrix of diseases and injuries, and let's say you have sensitivity and specificity for every cause, that matrix and try to transform it, well, you can show that that's actually quite unstable in the sense that small changes in specificity, when you're looking at that full matrix, can lead to pretty dramatic differences in the estimated set of outcomes. So we've experimented, particularly for verbal autopsy data, because it's poor sensitivity and specificity. But that has not been a strategy that we've been very happy with. So we haven't really used that. And so we've used the sort of deep dive into detailed codes and mapping those into sepsis categories for our work on sepsis. By the way, the sepsis paper for the updated time series on sepsis will be coming out, I believe, November 12th. So there'll be more detail on the latest round around sepsis.
There's also a visualization tool on the IHME website called Microbe um, that has all of these results in an interactive fashion that you can explore. I have a few questions here on specific country and cause patterns that people are curious about. The first is someone asking to know more about the recent trends in CBD for younger adults, specifically IHD.
So in high-income countries and upper middle-income countries, we saw probably from the late 60s, depending where, late or early 70s, mid 70s, almost 40 years of steady decline in age-specific death rates. But then we've seen stagnation and actually increases in a number of jurisdictions. So, for example, in the US, where we do much more detailed burden of disease work at the county and race ethnicity county level, we see a third of counties, ischemic heart disease going up, not down. And, there's many explanations, but probably the leading explanation for the stagnation and reversal is the rise of overweight and obesity. And we've been doing some separate assessments in the US, for example, that suggest that if weight of the US population had stayed the same as 2000, life expectancy at the national level would be 3 years higher today if we hadn't gained the last 25 years of weight. As just one way to think about just how huge the obesity and overweight effects are. And that's the most credible theory that we have for essentially the end of the decline in ischemic heart disease and also cardiovascular diseases more generally. The rise of obesity is pulling up blood sugar. It's also pulling up blood pressure or stopping the decline in blood pressure. And so, it plays out on the cardiovascular causes, stroke as well as ischemic heart disease.
We also have a question about Niger. Can you please explain in detail for Niger having better hail than the US?
So it doesn't have better hail, much worse hail. What that last slide I was showing was a measure of health system performance. How high, for the level of spend, which is low in Niger, how far in hail units are they from the best achieved level of hail for that level of spend observed in the world and for that level of SDI? So taking those two things into account, what would you expect hail to be the best level achieved? And so for a low SDI, low spend country, Niger is very close to the frontier. So it's doing for that class of countries on their own, it's doing about as good as you can, but it still has much lower hail than the US. In contrast, if you look at the US, high spending, high SDI, there are countries in Europe, there are places like Singapore or Taiwan or Japan that have much better hail for being high SDI, high spending. And so that means, there's potential for the US, one would think, to catch up to those countries in terms of HAIL, independent of spending more or changing SDI. It's this notion of efficiency or performance that you get from the stochastic frontier analysis. And I commend to you the paper published in Atlantic Global Health in August that really dives into detail what this method is trying to bring out.
Thank you for that clarification. The next question I imagine is of interest to a number of people on the call. What would you suggest for country collaborators to look into when analyzing country-specific burden? Should we dive deeper into the previously mentioned focal areas such as NCD shifts, mental disorders, heat deaths, obesity rise, lead, sexual violence against children, healthcare access and performance, or would you suggest other areas? Are there any priority topics?
I think it depends really on the country. I always, it's part of the reason we created the burden of disease in the first place. It just start from the big picture. Because very often in any country that I've ever talked to decision makers in, people don't have access to the big picture and have a very distorted sense of what are the biggest problems. I had a very interesting experience. I was briefing the committee in the US Senate on appropriations, the people who figure out where the budget should be allocated to, and showing how the US was doing poorly compared to many countries in Europe, as an example. And this, very senior, sophisticated staffer for the chair of the committee said, "Oh, that must be because of maternal mortality." Now, the reason she said that is there's US has poor maternal mortality compared to Europe, but the contribution of maternal mortality to the gap in life expectancy or healthy life expectancy in the US compared to Europe is less than 1%. So lacking the big picture, the people tend to think about what they've read about in the news or in the media or people have presented briefs to them on. So don't underestimate the utility of just writing up the big picture. What are the big diseases and injuries? What age groups do they affect? What are the big risk factors, particularly relevant to many people in government, because they often don't know. We ran in the World Health Summit a little poll in between one of the panels when we launched GBD last week, asking what was the most important risk factor in the world. And I think 50% of the audience said water and sanitation. And if you've seen on the list, it's probably 20th. And just another reflection of, people don't walk around in their mind with, what are the big diseases, injuries, and risks. So that's of enormous value to hammer that home and bring it home. There's a lot to be done, I think, in looking at trends. There's both the size, but are things trending in the right direction? Or are things getting worse, particularly relevant for risks, but also for diseases? Think about what we were just talking about a moment ago about the reversal in ischemic heart disease. That should be a huge red flag in any given country if there's a reversal in trend for a cause. Things were getting better, now they're getting worse. We really need to rethink policy in that space. Another direction, of course, is to take a particular issue that may be neglected in a country and then dive deeply into it. What are the sex age distribution? How do you benchmark up against other countries on a neglected topic? Maybe lead is something that hasn't been receiving attention or whatever is in the data. So I think you can use the tools and GBD compare, and I think there's a lot to be done on benchmarking, where compare your country to peers that are, at least in the popular perception or in decision makers' perception, we should be as good as or better than that peer. And that can be a really strong motivator for interest. And then lastly, I think there's ways to use the curated data in the GBD to try to get some insights on how is the health system performing. So I think there's a lot to be done in that sort of space.
Thank you, Chris. And for those of you who who are in a position where you're wanting to be able to share these descriptive metrics with decision makers in your country. Uh, there is a session next week, several sessions actually, on how to use the GBD Compare visualization tool to do some of the exact things that Dr. Murray was just describing, benchmarking, comparisons, etc. So look at the healthdata.org website for more information about those free trainings that are happening. Now, I'll just close this out with one not complicated question at all to leave you with. This is an individual who's asked, how can academic institutions, governments, and WHO country offices collaborate more effectively to integrate GBD evidence into national surveillance and health planning?
That's a great question. And I think the way to do that is start with understanding, because there's so much in the GBD, and as whenever we sit down with governments or decision makers or WHO regional offices, they're always surprised at how much is already there. And then I think, with deeper understanding of what's there and what the advantages brought by this attempt to standardize and build up the capacity for comparison, you can start to develop demand essentially from government for more timely information, so that we can, I hope, over time become ever more timely in the GBD, so that decision makers can not be making choices based on data that's 5 years old, but much, much more timely. So it's about building the relationships and building understanding. And hopefully we can help in that in various ways as you go on that sort of journey.
Thank you so much, Dr. Murray, for your time in this session. I'm seeing a lot of emojis of clapping and hearts flying across the screen. So safe to say people have enjoyed it. And thank you so much to everyone on the webinar today for joining us and for your active participation and great questions. The GBD would truly not be possible without the collaborator network. So we really want to thank you for everything that you do. Once the GBD 2023 in Focus series is concluded, we'll have all the recordings and slides up on the collaborator portal. If we didn't get to your question today, and we're sorry about that, please send it to us at gbdsec@uw.edu and we will endeavor to answer your question one-on-one. Thank you again for being here. We look forward to seeing you at future webinars, and I wish everyone a wonderful rest of your day. Bye-bye.
Bye.